Hello, everyone, and welcome back to PodBites, where we break down complex medical topics into bite sized pieces, perfect for your commute, your coffee break, or whenever curiosity calls. My name is Feras, your host for today's episode, and sitting across me is the best football player you'll ever meet, the one and only Adam Khawli.
Hello, everyone. I'm Adam Khawli, and I'm really excited for this one. We're talking about something you see all the time in clinics, on exams, and honestly on your own skin sometimes common viral infections of the skin.
Yup, all those little bumps and blisters that patients point at and say, Doctor, what is this? Today, we'll walk through how the skin gets infected, who's at risk, and then go case by case through some of the most common viral infections.
So grab your coffee, or if you're driving, please grab your steering wheel and let's get right into it.
But before we jump straight into the infections, let's zoom out for a second, because not everything on the skin is an infection. Sometimes it's just hanging around. First big concept, our skin is normally covered in microbes. We've got bacteria like Staph epidermidis and some yeasts living there peacefully. That's called your normal flora. So just seeing an organism doesn't automatically mean infection.
Right? Think of normal flora like chill roommates who pay rent and don't bother you. Infection is when someone kicks the door, trashes the place, and eats all of your food. Now that's the worst.
So how do we define it properly then? Simply colonization versus infection.
Colonization means organisms are present but not causing any harm. No symptoms, no redness, no pain. Infection means the same organisms are now causing damage, inflammation symptoms, and signs the patient can feel or you can see.
And what usually flips the switch from harmless to harmful, Adam?
A big one, a break in the epidermal barrier. The skin is actually your largest organ and a physical and immune shield. If you get trauma, burns, or even a small medical procedure that breaks the surface, that's like opening a door so pathogens can get in and misbehave.
Exactly. Plus, there's the microenvironment factor. Changes in the balance of normal flora, like if you're on antibiotics, excessive moisture, or extreme dryness, can tip things in favor of an infection.
And don't forget immunity. If immune surveillance is weak, for example in diabetes or HIV, the skin can't clear invaders as effectively. So the same virus causes a bigger, nastier problem.
Okay, quick question for you. Who are the usual victims of skin infections?
So we've got some classic high risk groups. First, children. Their immune systems are still developing. They get minor injuries all the time, and they may often have conditions like atopic dermatitis that disrupt the barrier. Then, the elderly. Their skin gets thinner, wound healing slows down, and their immune system goes through age related immune senescence, basically becoming less responsive. Then, immunosuppressed patients, transplant recipients, cancer patients, or people with autoimmune diseases on immunosuppressants. And finally, anyone with a barrier disorder, like eczema or bullous disease, where the skin is literally compromised.
So, on exams, if you see a child with atopic dermatitis and recurrent skin lesions, or perhaps an elderly diabetic with a skin infection, your antenna should go up.
Exactly. Now, classification time. But don't worry, we'll keep it painless, unlike the four classicals we won last season.
Alright, hit me with it. I'm sure it'll hurt anyway.
We can group skin infections into bacterial, like impetigo, cellulitis, erysipelas, viral, that's today's focus, which includes warts, herpes simplex, molluscum contagiosum, and others, fungal, such as tinea infections and candidias, parasitic, such as scabies and cutaneous leishmaniasis, and mixed or secondary infections. For example, a viral lesion that gets secondarily infected with bacteria.
So now, let's take a look at our first case. A 7-year-old boy is brought to the clinic by his mom. She says he keeps getting these bumps on his hands and feet. They look like little rough pebbles. Some of them hurt when he walks, and there are a few near his fingernails too. On examination, you see multiple firm, rough, skin-colored papules over his fingers and around his nails, and a few on the sole of his foot. On the plantar lesions, you notice tiny black dots inside. What are we thinking about here, Adam?
That classic my kid has weird bumps visit. Those black dots are a huge clue. They're actually thrombosed capillaries, tiny clotted blood vessels. Already sounds like we're dealing with warts or verrucae.
That's right. What type of warts to be precise, though?
We have two types of warts, verrucae vulgaris and verrucae plantaris. Firstly, verrucae vulgaris, or classic common warts. These appear on the hands and around the nails. Secondly, we have verrucae plantaris, or plantar warts. These appear on the weight-bearing areas of the sole.
All right. Walk me through exactly what's causing these.
Alright, warts are caused by human papillomavirus, also known as HPV, which is a DNA virus. There are more than 100 HPV subtypes. Different types like different neighborhoods. Some prefer skin, other prefers mucosa, and they produce different clinical patterns. In regular cutaneous warts, the common types are HPV-1, 2, 3, 4, 7, and 54.
Neighborhoods. And what about genital warts?
For genital warts, they are associated with sexual activity. HPV-6 and 11 usually cause benign genital warts, whereas high-risk oncogenic types like 16 and 18 are associated with malignancy. Think cervical cancer and some other anogenital and oropharyngeal cancers. That's why HPV vaccination is such a big deal.
But now, how does the virus actually get in? I mean, the skin looks intact most of the time and usually looks normal.
Well, it usually sneaks in through microabrasions, tiny invisible cuts or breaks in the skin. That can happen with shaving, friction, or even just normal activities. HPV is transmitted through direct skin-to-skin contact, contaminated objects like towels, or through sexual contact for genital warts. Once inside, the virus infects basal keratinocytes, stays localized, and go into latent phase in those basal cells. Over time, it causes hyperkeratosis, which is thickening of the stratum corneum, and papillomatosis, which is a sort of wavy, exophytic surface growth. That's what gives warts their rough, bumpy look.
So, how do you differentiate between each type now?
Let's do this systematically, Feras. We will focus on the location and the way they look. Common warts, aka verrucae vulgaris, are firm, hyperkeratotic, skin-colored papules, often on the hands or periinguinal areas, so around a fingernail or a toenail. They can sometimes distort the nail if they grow around it. Plantar warts are deeper, on weight-bearing areas of the feet, usually painful when walking, and you see those black dots, thrombosed capillaries inside. Flat warts, aka verrucae plana, are smooth, flat-topped papules often on the face or extremities, and they're more subtle. Genital warts, or condylomata acuminata, are skin-colored, exophytic verrucous papules in the genital or anal areas. Large ones can look like cauliflower tumors.
And there goes my appetite for cauliflower. Wonderful.
Sorry about that.
All right. So, can you tell us how do we diagnose HPV warts? Do we need perhaps a biopsy every time?
Most of the time, no. Diagnosis is clinical, and you look at the appearance and location, and it's usually obvious. Dermoscopy can help you get an up-close look into the warts where you would see those black dots. If you do a biopsy, which is rarely needed, you'll see coliocytes, which are keratinocytes with perinuclear clearing caused by the HPV infection. But that's more of an exam fact rather than a real-life everyday step to do.
And what about the treatment? Because I know most patients are very freaked out by them.
True. But first key point, many warts regress spontaneously. The immune system eventually recognizes the virus and clears it, especially in children. So in mild cases, you can reassure and watch. If treatment is needed, we have several options including destructive methods, topical keratolytics, and immunodilatory or cytotoxic agents. Destructive methods include cryotherapy with liquid nitrogen, curettage, electrosurgery, or lasers. These physically remove or destroy the wart. Topical keratolytics, such as salicylic acid and trichloroacetic acid, also known as TCA, or retinoids, they peel and thin the hyperkeratotic layer. Immunomodulatory or cytotoxic agents, such as imiquimod cream, topical 5-fluorouracil, bleomycin, or intralesional antigens like PPD or Candida antigen, stimulate an immune reaction against the wart. And since prevention is always better than cure, it's very important to know about the HPV vaccination, which helps prevent infection with high-risk oncogenic type. Some vaccines also cover the low-risk genital wart types.
To sum things up, here are our big takeaways about warts. Now, they are common in school-age kids. They have multiple clinical types, and you would see black dots on dermoscopy and coliocytes on histology. We have loads of treatment options, but usually spontaneous resolution is very common. Now, let's move to our next case. A 5-year-old girl comes in with her dad. He says, "These little bumps started on her trunk, then more appeared on her arm and thigh. They don't seem to bother her much, but the number is increasing. On examination, you see multiple, small, dome shaped, shiny whitish papules, each with a tiny central dimple or umbilication.
That is a textbook case of Molluscum contagiosum. Whenever you hear dome-shaped shiny papules with central umbilication, think molluscum.
And what's causing this one, Adam?
Molluscum contagiosum is caused by the Molluscum contagiosum virus, also known as MCV, which is a pox virus. It's a benign, self-limiting viral infection.
Benign? Who usually gets it?
Primarily children aged 1 to 10 years, like our patient. It also affects sexually active adults, especially with lesions in the genital area, and immunocompromised patients like those with HIV, where it can be more severe and widespread.
And how does the virus spread? And what does it do to the skin?
Transmission is very similar to warts. Direct skin to skin contact, contaminated objects like towels, and sexual contact in adults. The virus replicates in keratinocytes in the epidermis. Inside those cells, you get large eosinophilic cytoplasmic inclusions called molluscum bodies or Henderson-Patterson bodies. This process is confined to the epidermis and does not invade deeper tissue.
Now, how did we say these lesions look like clinically?
They're dome-shaped, shiny, yellowish-whitish papules with a central umbilication. They can occur almost anywhere but are common on the face, trunk, extremities, and in adults, the genital area. Sometimes they become inflamed and red. That can actually be a sign that the immune system is kicking in and the lesion is on its way out.
All right, that sounds really good. As for diagnosis, what do we do?
It is usually clinical. Dermoscopy shows central umbilication and a pearly appearance. Histopathology would show those molluscum bodies we mentioned.
And finally, how do we manage them, especially in children?
First, we would reassure the father and tell him that most cases go away spontaneously over months. So observation and reassurance are perfectly appropriate, especially in children. If treatment is needed, for cosmetic reasons, risk of spreading, or immunocompromised patients, we can use physical destruction like curettage, cryotherapy, or lasers. But in children, we try to avoid painful procedures unless really necessary. Topicals include 10% potassium hydroxide, also known as KOH, solution, cantharidin, which is a blistering agent, retinoids, and imiquimod. And of course, prevention by avoiding sharing towels and direct contact with active lesions.
Now, for a quick practice question. Let's say you have a child with mild, uncomplicated molluscum contagiosum. What is usually the most appropriate initial management strategy?
The answer is observation, because it's a benign, self-limiting condition that often resolves spontaneously.
Time to move into the large herpes family. And no, not all of them are sexually transmitted. Let's start with a case for this one. Let's say you have a university student that came in with painful blisters on the lip area. She says she had a fever and sore mouth a few days ago, and now multiple painful grouped vesicles have appeared on a red base around her lips. She tells you that this isn't her first time getting these blisters and actually remembered having a really bad mouth infection as a child once with sore gums and many ulcers. What do we think is going on here, Adam?
Now that sounds like herpes simplex virus type 1, HSV-1, giving her recurrent orolabial herpes with a history of primary herpetic gingival stomatitis in childhood. Wow, I got it right.
Before we dive in, and bravo Adam for getting that right, give us the big picture of the human herpes virus, the large family picture.
So the herpes viridae family includes HSV-1 and HSV-2, Varicella-zoster virus, VZV, Epstein-Barr virus, EBV, cytomegalovirus, CMV, not to be mistaken with MCV, which is our second case talking about Molluscum contagiosum, HHV6, HHV7, and HHV8.
Wow, now that's a lot of nephews. Now you're telling me all these viruses are part of the same family called herpes viruses?
Yes, sir. They're all double-stranded DNA viruses, and the key feature is latency, meaning they hide in host cells and reactivate later. They spread mainly via direct contact or respiratory droplets, depending on the type.
Okay, how about we zoom in on HSV-1 and HSV-2? Can you just tell us what's the main difference between them clinically? Because that's what we're talking about.
For HSV-1, it infects above the diaphragm, mostly causing orolabial infections. HSV-2 infects below the diaphragm, mostly causing genital infections. But there is overlap. Either type can appear in either location depending on exposure.
So HSV-1 above and HSV-2 below. Now, I believe this infection is quite common, isn't it?
HSV-1 infects a huge portion of the population. In fact, more than 70% of people under 50 worldwide have evidence of HSV-1 infection. HSV-2 is more associated with sexually active adults.
Okay, now walk me through the pathogenesis like I'm a 5-year-old.
Okay, weird request, but sure. Primary infection happens when the virus is transmitted through mucocutaneous contact. Think kissing or sexual contact. The virus replicates in epithelial cells at the entry site, causing the initial lesions. Then, it travels retrograde along sensory neurons to the dorsal root ganglia, where it enters latency, like going into sleep mode. Later triggers such as stress, UV light, or immunosuppression reactivates the virus, which then travels back down the nerve to cause recurrent lesions in the same area.
I don't think a 5-year-old knows what the dorsal root ganglia is, but whatever. And clinically, could you just tell us how that appears on the skin or mucosa? Not as a 5-year-old.
Okay. Classically, you get painful multiple grouped vesicles on an erythematous base. With HSV-1, primary infection in kids can present as herpetic gingivostomatitis, with painful mouth ulcers and inflamed gums. Recurrent infections are the typical cold sores or fever blisters around the lips. For HSV-2, you get painful grouped vesicles in the genital area, often with dysuria and systemic symptoms during primary infection.
And how do we diagnose HSV?
For classic presentations, clinical diagnosis is often enough. PCR is actually the gold standard to confirm viral DNA because it's highly sensitive and specific. But there are a few other tests we can do as well. A Zank smear can show multinucleated giant cells. This is a quick bedside test though, and not very specific. Direct fluorescent antibody, DFA, and viral culture can detect the virus. But we don't usually do any of that. PCR is usually enough. And finally, serology can show past exposures.
And for our poor college lady, what should we do about her management, Adam?
Well, Feras, for HSV infections, they are usually self-limited. But we treat with antivirals like acyclovir, valacyclovir, or famciclovir to reduce symptom duration and viral shedding. What do they all have in common? They all end with clovir, so that's an easy way to remember it. For patients with frequent recurrences, we can use suppressive antiviral therapy.
All right, PodBiters, question time. What is the most common mode of transmission for the herpes simplex virus?
Tick.
Time is running out.
Tick, tick. Well, it's transmitted by direct contact with infected secretions or lesions. Not airborne, not really fecal oral, mainly direct mucocutaneous contact.
Let's bring in another case. Now, a 6-year-old boy, unvaccinated, presented you with fever and an itchy rash. On examination, he has multiple vesicles over an erythematous base, some fresh, some crusted, and they are all over his trunk and face. The lesions are at different stages of evolution. What is going on here, Adam?
Now that is a classic chickenpox, which is caused by Varicella-zoster virus, also known as VZV, and HSV-3.
How has the epidemiology of Varicella changed with vaccination?
Before the vaccination era, more than 90% of children got infected in childhood. After routine immunization, there was around a 90% decline in Varicella cases, hospitalizations, and mortality. These days, Varicella mainly appears in unvaccinated people or those with waning immunity, often adolescents or adults. Shingles, on the other hand, increases with age and immunosuppression. Countries with high uptake of the shingles vaccine, like Shingrix, see a significant drop in shingles cases and post-herpetic neuralgia.
As for pathogenesis, can you walk me through it?
Primary infection with VZV causes varicella, the diffuse chickenpox rash. After that, the virus becomes latent in sensory ganglia. Years and years later, when you're not 5 anymore, it can reactivate along a specific dermatome. That's shingles, aka Herpes zoster.
What about the classical clinical features of both Varicella versus shingles?
Varicella presents with multiple pruritic vesicles on an erythematous base, often described as dewdrops on a rose petal. The key is that lesions are at different stages, some vesicles and some crusts, plus fever and malice. Shingles presents with grouped vesicles and bullae on an erythematous base in a dermatomal distribution. Pain or burning often precedes the rash. A complication is post-herpetic neuralgia, which is persistent pain after the rash resolves.
And is the diagnosis just by clinical observation? Are doctors that lazy?
Well, almost always, yes. Zank smear can show multinucleated giant cells. DFA, viral culture, and PCR can confirm the diagnosis, with PCR being the gold standard. Serology can show past exposures. But again, we don't usually do all that. It's mostly just a clinical diagnosis because, as you said, doctors are lazy.
Wonderful. Now, for our poor little 6-year-old boy, how do we treat this and prevent it from happening to other children?
For varicella, it's usually self-limited in children. In adults, infection tends to be more severe, so we're more aggressive with antiviral therapy using acyclovir, valacyclovir, or famciclovir. For shingles, antivirals should be started within 72 hours of skin eruption to reduce severity and may also help lower the risk of post-herpetic neuralgia. Prevention-wise, we have the varicella vaccine for primary prevention in kids and the shingles vaccine for older adults to prevent shingles and its complications.
All right, PodBiters, our next case. Imagine a 3-year-old child was brought in during the summer with a fever, sore throat, and decreased appetite. Now, the script forgot the parents, so don't worry about it. A day later, painful mouth ulcers develop, and then a rash appears on the palms, soles, and buttocks. The lesions are small, grayish vesicles with a surrounding red halo, and they are not particularly itchy. What do you think is going on here, Adam, with this poor, alone 3-year-old boy?
Now that is a classic picture of hand, foot, mouth disease.
Wow, that must have taken so long to come up with.
I know, right? These lazy doctors, man.
Who's the main culprit virus here?
Most often it's Coxsackie virus A16. Hand, foot, mouth disease is a highly contagious viral illness, mainly affecting children under 10, though adults can occasionally be infected.
Coxsackie virus A16 causes hand, foot, mouth disease. How creative. Does it spread by contact?
Transmission is through respiratory droplets and direct contact with lesions. It's actually quite common worldwide, especially in childcare settings and schools. It typically peaks in summer and early autumn. The virus enters via mucosal surfaces, replicates in the oropharynx and gastrointestinal tract, then disseminates through the bloodstream, leading to those vesicular eruptions on the hands, feet, and you guessed it, mouth.
Okay, hold on. So they get a rash on their hands, feet, and the mouth, hence the name, but does it also start with a rash right away? Or does anything happen beforehand?
There are prodromal symptoms, including fever, malaise, sore throat, and decreased appetite. Then you get the lesions, painful vesicles or shallow ulcers in the oral cavity, non-pruritic gray vesicles on the palms, soles, and sometimes buttocks with an erythematous halo.
And for this poor alone 3-year-old boy, how do we diagnose and manage this poor patient?
Diagnosis is usually clinical. The distribution is very characteristic. Lab tests like PCR from throat swabs or vesicle fluid are rarely needed but can confirm the virus. Symptoms typically resolve in 7
Adam, stop scrolling, man.
Oh, my bad. 7 to 10 days. Management is supportive with antipyretics like acetaminophen or ibuprofen for fever and pain, providing good hydration to avoid dehydration in kids who don't want to drink because their mouths hurt. Oral anesthetics or magic mouthwash for oral discomfort, and soothing lotions like calamine for vesicular lesions if they're itchy. Prevention hinges on good hygiene, hand washing, disinfecting surfaces, and keeping infected kids at home during the acute phase.
Okay, guys, final skin condition for the day. Now, imagine a 4-year-old child who had a viral infection a couple of weeks ago, maybe a respiratory illness, but now the parents bring him in because he's developed a symmetrical rash of small, red-brown papules over his elbows, knees, face, and buttocks. The trunk is relatively spared, so what's going on here?
That distribution should make you think of Gianotti-Crosti syndrome.
What exactly is Gianotti-Crosti?
Well, it's actually called Gianotti-Crosti. Well, anyways, it's a self-limiting dermatosis often triggered by viral infections. It primarily affects children under 6 years old. The pathogenesis is thought to be an immune response to viral antigens rather than a direct viral invasion of the skin.
And it presents as a rash over the elbows, knees, face, and buttocks?
The hallmark is a symmetrical papular rash on the extremities, especially elbows and knees, plus the face and buttocks. So it's like a distal and facial papular eruption, if you get what I mean.
And let me guess, we diagnose it clinically.
You guessed it right. Diagnosis is clinical, especially if the patient has had a recent viral illness.
What about treatment? What should we do for this little boy? Does it go away on its own?
Pretty much yes. The condition is self-limited, so management is actually supportive. just like most infections we talked about during this episode. If the rash is itchy, you can use antihistamines or topical corticosteroids for pruritus. Otherwise, reassurance and time are the main therapies. You know what they say, time heals all.
And for our final practice question before we wrap everything up, can you tell us what type of skin lesions and distribution is typically seen in Gianotti-Crosti syndrome?
Symmetrical erythematous papules on the face, buttocks, and extensor surfaces of the elbows and knees.
All right, PodBiters, let's do a rapid recap so you can mentally screenshot this episode and have it locked in.
We started with the basics. The skin normally has flora, like staph epidermidis and yeasts. Colonization means organisms are there but harmless. Infection means they're causing damage. A break in the skin barrier, changes in the microenvironment, and impaired immunity can all shift the balance towards infection.
We then talked about warts. Clinical types include common warts on hands and around the nails area, plantar warts with painful deep lesions and black thrombosed capillaries, flat warts on face and extremities, and genital warts, condylemata acuminata, linked to sexual activity. Diagnosis is mostly clinical, but dermoscopy would show black dots and biopsy would show collucites. Management ranges from watchful waiting to destructive therapies. And don't forget prevention by HPV vaccine.
Next up, Molluscum contagiosum is a pox virus infection. It's benign and self-limiting. It affects children, sexually active adults, and immunocompromised patients more severely. Lesions are dome-shaped, shiny whitish papules with central umbilication. I swear if you forget this. Diagnosis is clinical, and management is often just reassurance with options like curettage, cryotherapy, or topicals like KOH, cantharidin, retinoids, or imicimod if needed, plus hygiene to prevent spread.
Then, for the massive herpes virus family, HSV-1 usually causes orolabial infections, HSV-2 usually genital. Clinically, you will see painful grouped vesicles over an erythematous base. Diagnosis is clinical, but other options include PCR as gold standard and other available tests, such as Zank smear, which would show you multinucleated giant cells, DFA, culture, and serology. And don't forget to put them on antivirals like acyclovir, valacyclovir, or famiciclovir. Remember, the ones ending in clovir. And additionally, suppressive therapy for recurrences.
For VZV, we talked about varicella and shingles. Primary infection causes chickenpox, with lesions in different stages, plus fever and malaise. Reactivation along dermatomes causes shingles, with grouped vesicles and pain that may precede the rash, plus risk of post-herpetic neuralgia. Diagnosis is similar to HSV, and management includes antivirals, especially within 72 hours for shingles. And don't forget the Varicella and zoster vaccines for prevention.
We also went through hand, foot, mouth disease, the very thought out name, mainly due to Coxsackie virus A16. It affects children under 10, spreads in childcare settings, and peaks over the summer and early autumn periods. Clinically, you see fever, malaise, sore throat, decreased appetite, painful oral ulcers, and non-pruritic gray vesicles that don't itch, with an erythematous halo over the palms, soles, and buttocks, hence the very well thought out name. It's usually diagnosed clinically and managed with supportive care.
And finally, Gianotti-Crosti syndrome, which presents with a symmetrical papular rash over the face, buttocks, and extremities, especially elbows and knees. Diagnosis is clinical, often with a history of recent viral illness, and management is supportive with antihistamines or topical corticosteroids for the itch if needed.
And thank you so much, Adam. With that, we conclude today's episode on common viral skin infections. We went through a long journey from normal skin flora and barrier defenses, all the way to warts, molluscum, herpes, varicella, hand, foot, mouth disease, and Gianotti-Crosti. Hopefully in a way that actually sticks.
Thank you so much for listening. If you enjoyed this episode, share it with a friend who always panics when they see a skin rash. And don't forget to follow us so you don't miss future episodes.
Stay curious, stay kind to your skin, and remember, not every bump is out to get you. But the high-yield ones definitely show up on exams. Stay healthy, folks, and best of luck on your exams.
Thank you so much for tuning in to PodBites. See you in the next episode.
Wow. know, is this the script or doctors must have been so lazy to come up with this name?
انت خربت ماي بارت كمان ترى. اول مره it was so perfect انه انا I'm going off of you. انت غيرت كل السكريبت تبعي وتبعك.
خلاص I got you. I'll stick to the script. It's so fun. And for this poor alone 3-year-old boy.
I mean, I thought that was
What about the treatment? What does this little boy go?
Tick,
tick, tock, tick, tick, tock, tick, tock. All right, pair biters. Let's finally do. Okay, مرة تانية. All right, pair biters. Or pair biters. Pair biters. طيب. Are true?
all right.
Whoosh. PodBites, we're the PodBiters.
خلوا له اياها لحاله. خلوا له اياها.
What exactly is Gianotti-Crosti syndrome? Oh, hold on, I should butcher the name.
Yeah.
Okay, I'll start again.
See you in the next episode.